Hello and welcome. Today's topic, we will be discussing the respiratory system, also known as the pulmonary system. So again, you might see those terms kind of used interchangeably, but we will go ahead and get started. I think our textbook refers to it as the respiratory system, which is why I've listed it as the respiratory system here. However, I think, next half of this course, if you're planning to stick around for anatomy and phys 2, I might refer to it as the pulmonary system. Again, use them interchangeably. So let's take a look at some of the functions of this particular system. Again, pretty easy. What we want to accomplish, we need to supply oxygen to the body. We also need to get rid of CO2. So basically, those are the two main functions that we see within this particular system. How do we achieve that? So let's take a look at some of these processes here. So pulmonary ventilation, let me get my little pointer out. Okay, pulmonary ventilation just basically means bringing air in and out of the lungs, okay? External respiration is the movement of oxygen and CO2, the movement of gas molecules from inside of the lungs to into the pulmonary capillaries. Okay, so external respiration actually looks at the movement of gases from inside the lungs to into the pulmonary capillaries. Okay, next thing we're going to do is we're going to transport respiratory gases through the blood. And then lastly, internal respiration has to do with the movement of those gaseous molecules from the blood into the tissue so that we can use them. So again, oxygen, for example, will be transported via red blood cells. And then in order for internal respiration to occur, I'm going to drop off those oxygen molecules at the level of a tissue. Okay. Internal respiration can also mean the reverse. So I want to pick up waste products. So I might pick up CO2 at the level of the muscle and put it into the bloodstream so that I can take it back to the lungs. Okay. So pulmonary ventilation, again, is the movement of gases in and out of the lungs. External respiration is the movement of gases from the lungs into the, to the bloodstream. Then we'll transport those gases in the bloodstream. And then lastly, internal respiration has to do with movement of gaseous molecules in the blood into the tissues, muscles, organs, etc., and vice versa, moving those gas molecules out of the tissues and into the blood. Okay. Let's see. So when we think about functional anatomy of the respiratory system, again, we've got to understand the different components associated with this particular system. The nose, pharynx, larynx, trachea, bronchi, bronchioles, and then lastly, the alveoli. So we'll take a look at each of these individual structures and how they are designed as it stands from an anatomical setup. Okay, so again, here you can see the relationship between the mouth here and the nose would be up here. We have this kind of common ground, which we know is the pharynx. Then the larynx is anterior in comparison to the esophagus. Again, we know that the esophagus is like our tube that we are going to eat food, or the food will travel down. And then the trachea is here in front or anterior, and that's going to allow us to bring air in and out. Okay. Again, here you can kind of see the relationship between that trachea, which again we said was anterior in comparison to our food tube. Okay. And you can see that this trachea is then going to be split off into what's known as primary bronchi. Okay. So you can see a right and a left branch of those, and then those are going to branch into like smaller tubes, which are known as bronchioles. Okay. And then those bronchioles are going to lead into these little like circular things. So again, imagine that these are like clusters of grapes. Okay, so each individual grape represents one alveoli, and that's going to allow us to serve as the site of exchange for gases. And those bronchioles are going to be like the stems of the grape bundles. And so they're going to carry air down to the alveoli, and then alveoli is where exchange is going to occur. Okay, so when we think about structure and function, again, pulmonary ventilation is that process of moving air in and out of the lungs. And there's two different zones within the lungs. We have a conducting zone and a respiratory zone. So the conducting zone includes respiratory passageways that carry air to the site of gas exchange. So that conducting zone, they're not actually going to contribute to facilitating gas exchange. Okay, so they're just simply a tube for which we can carry those gases. Okay, respiratory zone is the actual site of gas exchange, and this will include respiratory bronchioles, alveolar ducts, and alveolar sacs. Okay, so the conducting zone, again, as I mentioned, its primary function is to just simply carry that air from the outside world to the site of where exchange can occur. It also helps us with filtering, humidifying, and warming the air as it comes in as well. Okay. Again, the lungs will provide the gas exchange surface, which allows gas to move from the alveoli into the pulmonary capillaries in that process, which we said was known as external respiration. Okay. So here you can see the kind of the relationship between both of those. So we've got the conducting zone, which includes the trachea, the bronchi, and some of those bronchiole tubes as well. So again, just like within the cardiovascular system, like we start with a pretty big tube, and then those tubes are going to get smaller as they become more branched. And then once we get to the respiratory zone, again, remember that there's some bronchioles, also alveolar ducts and alveoli within that respiratory zone where exchange of those gases could occur. Okay, so next we're going to kind of go through each of these components as it's associated with their movement of air into the lungs. Okay, so the nose has 5 different functions. So the functions of the nose include providing an airway for respiration. Okay, it can moisten and warm air as it enters into the body. It can filter inhaled air of foreign particles. It serves as a resonating chamber for speech, and also houses olfactory smell receptors. Okay. So one thing that I think is super interesting, again, if you remember back to our first lecture, we talked a little bit about anatomical differences from people. And again, just trying to get a grasp of why people look differently. And I think the nose is one area that's super interesting when we think about our heritage and what's been passed down based on survival, basically. But people that have ancestors that lived in like Norway, Sweden, those types of places have longer, skinnier noses. And the reason that they have longer and skinnier noses is because it allows for more time for that air to become warmed as it enters into the body. Okay, so again, if you lived in a place that was pretty cold, that would be important. Okay, people that have their ancestry from like around the equator, so again, you weren't, your ancestors weren't exposed to much cold temperatures, are more likely to have like a flattened, shorter nose or like the wider nostrils. And again, the reason for that is warming the air isn't important because the air is already warm as it comes into your body. So again, I think that's kind of an interesting fact when we think about the differences of people and what we look like and things like that, and what we get from our heritage, and also like why we get it from our heritage. So anyway, one little kind of fact about noses. The external nose, move my little picture up here. So the external nose, you can see here. External nose consists of frontal and nasal bones superiorly. Okay, so again, the frontal bone and nasal bone superiorly. maxillary bones on the lateral side, okay, and also hyaline cartilage. So the hyaline cartilage will make up the soft portion of your nose as well. Okay. Again, differences in nose size can vary based on the amount of nasal cartilage that you have. Certainly there's some variation as it relates to our bony structures as well. You know, like people that have more prominent cheekbones, you know, that might affect their nose shape and that sort of thing. But the majority of your nose is determined by what that nasal cartilage looks like. And again, that's potentially, you know, that's a good portion of what that looks like is genetic in nature. The nasal cavity is going to lie posterior to the external nose. Again, the external nose will allow us to get that air in. So the air is going to enter in through those external nares or nostrils. Okay, and then it will move through posterior nasal apertures into the nasopharynx, and then lastly into the trachea. So what's going on with the lining? Okay, so we within the respiratory paths or within the conducting zone, the respiratory lining tissue is made of pseudostratified ciliated columnar epithelium with an underlying lamina propria. Okay, so here you can see the lamina propria underneath, which we know is a connective tissue layer that's going to help everything stay intact. Again, ciliated. We know that those cilia or those finger-like projections on the top are going to be important for movement of mucus and other items. And the columnar epithelium, again, you can kind of see here. Again, we've got goblet cells that are going to produce and secrete mucus. When you get a cold, for example, and you get a lot of mucus, the goblet cells are working in overdrive to try and fight off whatever infection or you know, whatever you've been exposed to, whatever virus. So again, that's one of the reasons why they secrete more mucus in those particular scenarios. Again, one of the side effects of that, again, when you get a cold, is you kind of sound super nasally. Like if you were to talk to somebody on the phone, they'd be like, oh, you know, you sound stuffed up, or you sound, you know, and again, it's kind of interesting to think because like you don't use your nose when you talk. However, if you block off that chamber, it creates a different sound. So, you know, that resonating chamber that we mentioned with one of the functions of the nose can be impacted when we are sick and things are kind of clogged up in that particular area. Okay, here you can see that upper respiratory tract. Again, just another image to show you those components. So you can see the nose or the nostril, external nostril here, and then, excuse me, then the air will move into the nasopharynx again through the oropharynx, and then it will move forward through the laryngopharynx into the trachea here, okay? So again, when we eat, food comes into the oropharynx, so this serves as kind of a common ground for us for food and air both. So again, as mentioned, this passageway connects the nasal cavity in the mouth to the larynx and the esophagus inferiorly, also the trachea as well. Okay, so the nasopharynx is going to be superior to the soft palate and only serves as an air pathway, okay? So the nasopharynx is not going to have any food in it because it's superior to the mouth, okay? The oropharynx is posterior to the oral cavity. The oropharynx and the nasopharynx meet here, okay? So the nasopharynx is superior, and then next comes the oropharynx, okay? Then lastly, the laryngopharynx serves as a common passage for both food and air, and it's continuous with the esophagus, okay? Again, know that you also have the option to move to the trachea when necessary. Okay, here you can just see another image of those components. So again, nasopharynx is superior to the mouth or that oral cavity. Oropharynx, again, will serve as a common ground for both food and air, along with the laryngopharynx, which is our most inferior of the three components. And that will lead us directly into the esophagus, but know that we also have the option to move forward into the trachea if I have air, which is kind of weird to me to think about. Like, shouldn't the air pathway be like the main pathway? Because don't we spend more time breathing than eating? But I don't know, whatever. I guess the air is easier to move than the food, so maybe that's why it's set up that way. I don't really know. I'm just kind of talking. All right, so now we're on to the larynx, also known as the voice box. And this, you can see, is located here, just, you know, underneath the oral cavity, but above the trachea and esophagus. Has three functions. It's going to produce vocalizations, okay, allows us to talk, provides an open airway, is number 2, and acts as a switching mechanism to route food and air to the appropriate tubes. Okay. All right. So again, the larynx is where we produce sound, okay? And it's going to contain paired vocal ligaments that are composed of elastic fibers. Here you can see those here. And exhaled air causes the vocal ligaments to vibrate in a wave motion, producing sounds, okay? So again, the tightness of these ligaments determines our pitch. So like if you talk really high or really low, has to do with the tightness of these ligaments here. And so like when we learn to sing, for example, we can learn to manipulate these ligaments to create the appropriate sound or the appropriate tone that you want to make. If we want to be loud versus quiet, again, that doesn't necessarily have a huge effect on those elastic fibers. However, it's just about like the volume of air that you're producing in order to change the volume of your voice. Okay. Next, you can see the trachea. This is not a good picture. I don't know what this is going on here. So again, epiglottis lies here. The trachea, again, lies anterior to esophagus, which is on the posterior side, and it is directly inferior to the larynx. Okay. Trachea, also known as the windpipe, and it will eventually divide down here into two main bronchioles or bronchi. Contains 16 to 20 C-shaped rings of hyaline cartilage. And again, you can feel those, you can palpate those on your neck, and you should be able to kind of feel around and feel something there. Again, I want you to think about, why would I need cartilage here on the front of my trachea? And again, the reason is that this is going to help us keep that tube open, but it's also protection. I mean, has anybody ever been hit in the throat, you know, not on purpose or anything, but like in sport, for example, like sometimes that happens. Sometimes you get hit with, you know, a hand or a ball or whatever when you're doing a sport or whatever. So that's protective for us. So this cartilage isn't like great. I mean, it's not as good as like, you know, like your sternum is super protective, but it's something. I mean, it gives us some sort of protection, so that's good, at least. So it gives us some protection. It's flexible, which allows us to have some bending. So again, we can do lots of different things with the cervical region, which is great. So we have a lot of mobility in that particular area. And it ensures that those tubes are going to stay open when doing so. Next, we're going to take a look at the bronchial tree. So here you can see the different branches of the bronchial tubes as we move from superior to inferior, essentially. Okay, so again, from the trachea, we're going to break off into the right and left main bronchi, which are known as the primary bronchi. And then we are going to move into secondary bronchi, and then segmental bronchi or tertiary bronchi into the bronchioles, and then finally into terminal bronchioles, which will lead into those alveoli, or those little grapes that we mentioned. Okay. The right and left main bronchi are also called primary bronchi. Again, they're the largest of the bronchial tubes, those main ones. These passageways branch into the lungs and end with terminal bronchioles. So what's going on with the tissue? So again, if we were to zoom in under a microscope, what's going on with the tissue within these conducting tubes? Okay, so as the conducting tubes become smaller, the following changes will occur. Number one, the supportive connective tissue changes. So cartilage rings in the trachea are replaced by plates of cartilage as the main bronchi enter the lungs. Okay, so again, imagine that you had like these C-shaped rings, and then they're gonna like get a little bit smaller and smaller until they're just like a little flattened piece, basically. So again, remember that this is gonna be gradual, this process. And then they're eventually, again, they'll be replaced by just plates of cartilage. So just tiny little straight plates of cartilage as they enter into the main bronchi. Okay. Second change that occurs, the epithelium changes from mucosal epithelium to pseudostratified columnar to simple columnar to simple cuboidal. Okay, so a lot of change going on there. Let me say all that again. So we're going to start with mucosal epithelium. So it's like a tissue that's got a bunch of mucus, or like the goblet cells, so that it can produce a bunch of mucus. Then we're moving to pseudostratified columnar epithelium. Next is simple columnar. Next is simple cuboidal. Okay. So again, I want you to think about this logically. And again, we went from columnar to cuboidal. We're eventually going to get to squamous. But think about this progression. And I want you to think about what's going on in these various locations as we move this air in. Again, when we bring in ambient air, that's super dangerous for us, right? There could be toxins out there, things that we're allergic to. It's easy for us to catch infections, clearly, and things like that. So it's important that we're protecting ourselves then, right? So these bigger cells are going to allow us to have this mucus so we can catch anything bad, right? But as we move down the bronchial tubes, we need to modify those cells, and those cells are going to become smaller or shorter as we get to those simple cuboidal cells. Okay. Again, I'm going to transition from protection to now respiratory exchange eventually. So I'm gradually kind of changing the tissue as I move down the tube in order to account for this change in function that's coming up. Okay. The last change that we see, smooth muscle will eventually replace those cartilage rings as we move inferiorly into the bronchial tree. Okay, this allows us to widen the respiratory passageway or constrict the respiratory passageway depending on the situation, right? So that's great news. So when I exercise, I'm able to vasodilate these tubes, which means I can get more air in the respiratory passageways because of the smooth muscle that's located surrounding those tubes as we move down the, like I said, that bronchial tree. So that's pretty neat. Okay, next let's take a look at the respiratory zone versus the conducting zone. Here you can see, let me move my little figure. All right, start over here. Again, conducting zone, here you can see we've zoomed in on the respiratory zone here. The respiratory zone consists of structures that contain air exchange chambers known as alveoli. So again, each of these little balls here, or I refer to them as like a little grape, is one alveoli. It also contains respiratory bronchioles, which you can see here. Alveolar sac is like a cluster of grapes, and then alveoli is each individual grape. This is basically the same picture. I'm not really sure why I included both, but again, I'm a visual learner, so I like to have lots of pictures. But here you can see each little circle is one alveoli. The alveolar sac is like a cluster of grapes, and then those respiratory bronchioles are like the branches that are going to hold those grapes together. So we mentioned that that tissue was changing, and we said that it was changing from, mucosal cells to columnar to cuboidal, right? The next thing that's coming is they are squamous, or those flattened cells, as we enter into the alveoli, okay? The alveoli, we have a shit ton of these. We have 300 million of these. We have 300 million little grapes within the lungs, and it accounts for the majority of the lung volume. So that's awesome, okay, that we have so many of these. What does each of these look like, right? So the walls of the alveoli consist of a simple squamous epithelium, so again, flattened cells, and they're called type 1 cells, okay? They also have these type 2 cells interspersed, and these type 2 cells that are interspersed in the walls of the alveoli are going to produce a product known as surfactant. And we'll talk about that in just a second. Other kind of facts about alveoli, the walls are extremely thin. Okay, think of like a cobweb, and that's kind of how thin the alveolar walls are. Okay. Again, this is the site of gas exchange, also called the respiratory membrane. The respiratory membrane is the interaction between the alveoli and like the capillary. Here you can see there's one capillary. Well, there's a couple capillaries. Okay. Gas can pass easily in either direction. So once we get gas to the alveoli, we're pretty darn good at being able to move it either direction. So that's nice. That surfactant that we mentioned that comes from these type 2 cells has one job. It's going to help us to decrease the surface tension of the alveoli and helps the alveoli to keep from deflating. Okay, so I want you to think about like blowing up a balloon, for example. Okay, so when you first start blowing it up, it's like really hard, but the larger the balloon gets, the easier it becomes to continue to blow up. Okay, and the reason for that is as the balloon gets larger, the surface tension is going to decrease. That's kind of the same mechanism of what surfactant does. Surfactant's job is to decrease that surface tension so that it's easy for these molecules to like stay inflated, basically, right? Okay, one thing that I wanted to kind of point out, I have a lot of pictures in this. That's nice. In this lecture. One thing I wanted to point out here is just the density of capillaries that we see within the respiratory system, right? So here you can see the capillaries, the pulmonary capillaries just really enclosing around each individual alveoli. Again, think about how important this process is. Like if I don't have oxygen, if I can't get rid of waste products, like I'm good for nothing, right? So it's important that we have a dense capillary network surrounding each individual alveoli. Okay. Here we can see that respiratory membrane that I mentioned. Here is an alveoli. We can see those type 2 cells, which are going to produce surfactant, which allow us to decrease surface tension. And then the type 1 cells are made of these simple squamous kind of flattened cells, which are very thin, which allow us to facilitate exchange super easy. Okay. Here you can see a capillary as well. Okay. So a capillary, it's got some red blood cells in here, and it's interacting directly with the alveoli. Notice that this single alveoli has many capillaries available. So you got like 1, 2, 3, 4, 5, 6 potential places where I could facilitate exchange of gas. And that means getting gas, like getting waste products moved into the alveoli and getting oxygen moved from inside the alveoli into the blood. Okay. So the respiratory membrane, again, here we're kind of zooming in over to here on what's going on. Okay. So I have alveolar epithelium, so that's the alveolar wall. Okay. And then I also have the capillary endothelium, which is basically like the inner lining of the capillary. And again, I want to move oxygen from inside the alveoli to the red blood cells, and I want to move CO2 from in the red blood cells or in the blood into the alveoli. Okay. So again, that gives us some information about what's going on from an anatomical standpoint as we look at, you know, the lung in general. And next thing we want to do is kind of take a zoom out here and take a look at the gross anatomy of the lungs. So when we are looking at this particular individual, the base of the lungs is actually at the bottom here. This is the concave bottom of the lungs, and the diaphragm will sit directly underneath here, and we'll talk about the importance of the diaphragm here coming up. Okay. Also, we have superior lobes on both sides, both the left and the right side, inferior lobes on both sides. And notice that on the left side, I only have 2 lobes. Okay, so again, remember I'm looking at this guy or this person, and I've got 2 lobes on the left, superior and inferior. I also have a cardiac notch. What's that doing over there? That's where the heart sits. So again, because the heart is slightly off-centered, I only need 2 lobes of the lungs on this particular side. Okay. On the right side, I have 3 lobes. I've got superior, middle, and inferior. Again, this lung looks like slightly bigger because I have the heart kind of off-centered onto this side over here. What else? Oh, the apex of the lungs is this top tip as well. Okay, you can see the apex here anyway. So again, left lung, I have 2 lobes. I have a superior lobe and an inferior lobe. Also, the base is kind of this concave surface down here where the diaphragm sits. The apex is at the top. I also have some fissures as well. I have horizontal and oblique fissures. Oblique fissures are found on both sides. Again, this is going to separate the superior and inferior lobe on the left. And the oblique fissure will separate the inferior and middle lobe on the right side, and a horizontal fissure will separate the superior and middle lobe. So again, if you remember back to the cardiovascular unit that we talked about, we have blood supply coming from the right side of the heart, and our pulmonic circulation is going to be made up of pulmonary arteries. And pulmonary arteries are going to take blood away from the heart and deliver it to the lungs. Pulmonary capillaries, which are going to facilitate exchange at the level of those alveoli. So again, that involves the capillaries picking up oxygen from the lungs and getting rid of CO2 or waste products. Okay. And the pulmonary veins are going to carry that oxygenated blood back to the left side of the heart so that we can then send it out via systemic circulation. Okay. Additionally, another review slide I would think for you would be the pleura, or these connective tissue layers that we have within the lung. Again, if you remember back to lecture number 1, we talked about these connective tissue layers and why they were important. But we have the parietal pleura. Again, parietal means parent, so he's on the outside. He's the most external of the layers. And then internal, we have the visceral pleura, which will lie internal to there. The pleural cavity is the space between these 2 connective tissue layers. It's got some serous fluid in it as well. Again, if you imagine how many times we breathe, which is about 10 to 12 breaths per minute approximately for the average person. And every day, every minute, every, year of your life, we're doing that, and we're doing it right, I guess. We don't mess up or anything else like that. So it's important that we maintain the serous fluid so that we're not having any abrasion. And it's also important for us for keeping the lungs inflated as well. Okay, so here you can see kind of that relationship between the parietal pleura and the visceral pleura. So again, parietal is external and the visceral is internal, and we kind of have that pleural space in between, which has some serous fluid in it. And again, that's going to allow us to prevent abrasion or like friction, but it's also going to help us to maintain like the suctioning power that allows us to keep our lungs inflated. Okay. So, as I've alluded to, we have this whole thing of pleural pressure, right? So we have a negative pressure, or the suctioning pressure, that lie in between these two layers, okay? So think of this as like when a dryer sheet sticks to you, you know, it's like the suctioning power, and it's hard to pull it off, right? They want to be close to each other, the dryer sheet and like your pants or whatever, right? So we have this negative pressure that creates a suctioning power between these two layers. And this negative pressure is super important because that's one of the only things that allows us to keep our lungs inflated. Our lungs are full of like a bunch of elastic fibers, basically. And so they want to recoil smaller, right? So imagine like a rubber band. If I stretch it out, it wants to recoil back to its original resting length, okay? So imagine that your lungs are inflated like this, and they're inflated against the will of these elastic fibers. And the way in which they're going to stay inflated is because they've got this negative suction, or this negative pressure between these pleuras that allows them to stay open, right? So if I were to get in some sort of accident, like let's say like a car accident, or like I got shot by a bow and arrow or something like that in my ribs, and it went in through like one of my ribs, it'd be very likely that I would suffer a collapsed lung, right? So what happens when I lose the suctioning power is the lung collapses and it closes in on itself, and it, you know, that elastic recoil mechanism will kind of take over and prevent that lung from being able to be expanded. Okay, so let's talk about ventilation and how we get to bring air in. I think this is super interesting. So all mechanisms of pulmonary physiology are based on a series of pressure gradients. Okay, so in order for gases to move, they're going to move down a pressure gradient. Okay, so Fick's law of diffusion is that movement of air is based on pressure gradients. Okay, so if the pressure in the outside world is 100 and the pressure inside my lungs is 50, the air wants to move so that it reaches equilibrium, okay? So I would tend to want to get air in order to balance out this difference of 50 and 100, okay? So let's take a look at how this actually works. Okay. So inspiration involves muscular action of the diaphragm, external intercostals, and we're getting some aid from pec minor and sternocleidomastoid, okay? So what do each of these muscles do, and how is this related to inspiration, okay? So the diaphragm is like kind of, let's see if you can see me here. It's like up underneath our ribs, right? It like sits right under the lungs. And when I go to breathe in, hang on, I'm going to push that diaphragm down, actually. Okay, so when the diaphragm contracts, it presses down, and that's going to allow me to open up the thoracic cavity. Okay, external intercostals are going to help me to pull the ribs out and up. Okay, so they're going to pull the ribs anteriorly and superiorly. So again, we can understand why those two things together are important in order for inspiration to occur. Diaphragm pushes down, the external intercostals are going to push out and up, creating a larger cavity, a larger thoracic cavity. Okay, pec minor and sternocleidomastoid are also going to help to pull the ribs up or superiorly. Okay, so let's take a look at what this means as it relates to pressure. Okay, so again, imagine that I have my thoracic cavity, just its regular size, And in order for me to get air to flow in, I need to change the pressure within my lungs, okay? So the pressure here needs to be lower than the pressure in the outside world in order for us to produce a pressure gradient that will allow air to come into the lungs. Okay, we have to entice the air in some way, and it wants to be at equilibrium. So it wants to move from an area of high pressure to low pressure. So in order for us to do that, we have to manipulate the pressure within the lungs. Okay, so what we're going to do is we're going to contract the diaphragm. That pushes down. We're going to contract those intercostals, which are going to bring the ribs up. Going to bring the ribs out anteriorly and up superiorly with the help of pec minor and sternocleidomastoid. And those changes are going to allow us to increase the volume, okay? So again, try it at home, right? So as I take a big breath in, I increase the volume of the thoracic cage, okay? So as I increase the size of the thoracic cage, this causes me to decrease pressure in here, okay? As a result of the decreased pressure in my lungs, air will rush in until I reach equilibrium, okay? That's basically what all of this says. Keep it to my version if you want to keep things simple. Basically, in order for inspiration to occur, I need to contract those muscles so that I, A, increase the size of the thoracic cage or the thoracic cavity, and B, that's going to cause a decrease in pressure inside of the lungs. As a result of that decreased pressure, I've established a pressure gradient. So the pressure outside of the lungs is greater than the pressure inside of the lungs. So therefore, the air wants to move down its pressure gradient to reach equilibrium. So it's going to come into the lungs. Okay. Now, when we decide to do expiration, this process is generally passive in nature. So all we're going to do in this scenario is relax. Okay, so you breathe in big. Your relaxation is what allows us to get back to kind of that expired position, okay? So the diaphragm relaxes, and again, we pushed it down before, so as the diaphragm relaxes, it's going to come up and underneath the lungs, okay? Those external intercostals are going to relax, which means that the ribs are going to go down and in a little bit, so they're going to move back inferior and posteriorly. Okay. We also have the elastic recoil of the lungs, which I alluded to previously. Okay, so again, like a rubber band, as I stretch out the lungs, they want to return back to their original position. Okay. So that's what happens when we're at rest. That's like normal. Okay. During exercise, or when we need to breathe forcefully out, like if I were to blow up a balloon or to play a musical instrument that, you know, like the flute or the trumpet or something like that, that requires me to like blow into the instrument, and I need to create a forceful expiration. So if I want to create a forceful respiration, I'm going to do all of those things that we mentioned, plus a little bit more. Okay. I'm also going to activate internal intercostals, which are going to allow me to forcefully pull the ribs in and down. And I'm also going to contract my abdominal muscles. Okay. The abdominal muscles, that's something that's kind of like, I think, a surprise to a lot of people. And again, why would I need to activate my abdominal muscles in order to breathe out forcefully? We'll try it at home and see if you do actually activate them, particularly if you are trained in music, whether it's singing or with an instrument. You're trained to use breathe. You know, a lot of musicians will talk about breathe from your belly, you know, and again, they're talking about utilizing or activating the diaphragm fully, but they're also talking about we've got to use our abs in order to get this accomplished. Okay, so the contraction of my abs is going to create more compression, and that's going to allow me to forcefully get the air out. Okay, so how does this happen? All right. So again, remember that with inspiration, we had an increase in volume, a decrease in pressure inside the thoracic cavity, air rushed in. Okay, once that air is at equilibrium, now I'm ready to expire. So I'm going to have elastic recoil of the lungs. I'm going to relax those inspiratory muscles and contract those expiratory muscles if it's a forceful situation. So again, that's going to cause me to decrease the size of my thorax, which means I'm going to increase the pressure inside of my lungs. Okay. And as a result, the pressure inside is greater than the pressure outside. So the air wants to get out to reach equilibrium again. And that's going to force the air to exit out via expiration. Okay. So again, those concepts of volume and pressure are a lot of times confusing to students. So, watch that section over a few times. If we need to talk about it over Zoom, I'm happy to do so, so that you feel comfortable with what's going on with those particular mechanisms, because again, that can be a little confusing for some people. Let's take a look at regulation of ventilation. So it's pretty complex how we actually regulate how much and how often we're breathing. However, keep in mind that this is all autonomic in nature. I don't have to think about like, okay, breathe. I don't have to, spurred on a yawn. I don't have to consciously think about breathing, right? So that we know that some of these things are occurring at a lower level. So the medulla is our respiratory center, and that's going to set a baseline for respiratory rate, which includes the depth of our breath. So like how deep you're breathing, but also the frequency. So how many breaths are you taking per minute? So that's kind of like where the baseline comes from. And then we have some chemoreceptors that are going to help with the fine tuning of it. Okay, so chemoreceptors we know are going to monitor chemical changes. They're located in the aortic arch and carotid arteries. So again, the aortic arch is going to send blood out to the entire body, and those carotid arteries are going to send blood up to the brain. So it's pretty important locations in terms of like where we're going to monitor these chemical changes. And they're going to monitor changes in oxygen, CO2, hydrogen, a bunch of different stuff. What are they most sensitive to? Like, what are they going to tell the medulla about first? Is actually CO2 levels. Okay, so if my CO2 levels get too high, that's going to trigger or stimulate the medulla to change or modify my breathing depth and rate as well. Okay, so these chemoreceptors are going to monitor changes in oxygen and CO2, but they're most sensitive to changes in CO2. Oh. Hang on. I didn't print this one out. Again, what are the chemoreceptors stimulated by? As we already mentioned, here you can see the aortic arch and the carotid artery, both containing chemoreceptors and baroreceptors. Baroreceptors are going to monitor pressure, so like your blood pressure, for example. But again, they're going to be stimulated. The chemoreceptors will be stimulated by chemical changes such as CO2, oxygen, and hydrogen. Those are the ones that are important for us when we think about respiration. Yeah. We can also, take over the medulla and have some kind of voluntary control over breathing. Can you think of some examples of when it's important to voluntarily control your breath, whether that's an activity or otherwise? Give you a hot second to think about it. There are certain scenarios such as like swimming, for example. I can't just breathe whenever I want all willy-nilly if I'm swimming, so I need to have some voluntary control over breathing. Okay, so I am going to have some descending pathways from the cerebral cortex to those motor neurons, which can allow me to modify breathing to meet those needs. Okay, again, Singing, music is another great example of when I'm going to have voluntary control over my breathing. Also, you know, maybe you've noticed this or maybe you haven't. Like if you lift weights, you should be thinking about breath control and when to breathe and that sort of thing. Lots of other scenarios when you do a complex task. Sometimes we are trying to manipulate breathing in those particular scenarios as well. So again, we're gonna modify those based on that complex task, and that information can come from the cerebral cortex. However, the voluntary control cannot be maintained when involuntary stimuli such as elevated CO2 levels are high. Okay, so if I'm trying to swim as fast as I can, for example, and I'm trying to maintain a certain like pace. So again, when I swim, like every 4 strokes, I'm going to breathe. Okay. So 1, 2, 3, breathe. 1, 2, 3, breathe. 1, 2, 3, breathe, etc. You get it, right? If you're not familiar with swimming. Anyway, that's like my steady, like that's a coordinated plan. Like that's just like your normal rhythm, right? But let's say I'm trying to go super fast, right? So let's say I'm like racing or whatever, or something along those lines. I'm speeding up, okay? And if my CO2 levels get too high, well, I'm not going to be able to do that. I'm going to either suck water in, or I'm going to have to modify that plan, okay? So if the CO2 levels get too high from that involuntary stimuli, that overtakes your voluntary control, right? So then you end up gasping for breath or whatever. Okay. Again, we said some voluntary control is important for complex activities, singing, swallowing, speaking, but also, you know, rhythmic activities, yoga, swimming are 2 examples where it's important for us to really focus on breathing as well. So we can have some changes in ventilation. Again, exercise can increase our ventilation, as you probably could guess. And there are 3 mechanisms that are going to be responsible for monitoring changes in ventilation in an exercise scenario and otherwise. Okay, so number 1 is those chemoreceptors. Okay, those chemoreceptors are going to monitor changes in oxygen and CO2 and give us information about what our real need is based on what we're using and what we're producing. Okay, we're also going to get some cortical influence from higher brain centers. Okay, so again, if this is an activity that I've done before, this is going to trigger my mind to remember, like, oh yeah, when you swim, this is normally what you do, or oh yeah, when you run, you normally need to breathe more, or whatever. So it can activate your memories, essentially, of that activity so that you know how to modify breathing. Okay. Then also, one thing that is another factor is mechanoreceptors. And our mechanoreceptors are going to sense body movement. So yes, I told my brain that I'm going to swim, but now as I get in the water and I get started and things like that, I'm activating mechanoreceptors at the joints and at the muscles. And that's going to allow me to sense changes in body position and kind of also reinforces like, oh yeah, you're doing that swimming thing again that you do sometimes. Okay, like I think we need to breathe more for that. So all of those factors together are going to kind of work in conjunction in order for us to increase ventilation when needed. Okay, I think I have 2 disorders of the respiratory system to talk about. Asthma, I think, is an interesting one. It's pretty common. Asthma affects about 7% of adults and 10% of children. You can have it as a child and grow out of it, or you could not have it as a child and develop it as an adult. So again, you know, just because you had it one time versus the other doesn't mean that you're going to always have it. It can be related to an allergic inflammation or irritants in the air. So again, maybe you only experience it as it relates to allergies, for example. Symptoms include coughing, wheezing, and shortness of breath. Generally, it causes bronchoconstriction, so those tubes kind of shrink down a little bit, which is bad news if you want to do something like exercise, for example. So that can make it a little bit challenging. Treatments for this, we can give you an albuterol inhaler. And basically what the albuterol inhaler does is it prevents bronchoconstriction. So it's going to activate some like receptors that are located in the bronchial tubes, and that allows them to vasodilate against the orders of whoever told you to bronchoconstrict. Okay, so again, they're fairly effective. There are some side effects to utilizing that type of medication. Some people feel like rapid heartbeat, for example, might feel dizzy or lightheaded. So again, because it's kind of a stimulant, it can cause some other potential side effects as well. So that can be problematic for people as well. Last disorder I want to talk about, I believe, is cystic fibrosis. This is not as common. Certainly it's a genetic disorder, but basically it causes an oversecretion of mucus within the respiratory paths, and this will cause those pathways to become clogged. Again, it doesn't necessarily it doesn't mean nasally. It can be further down as well in those bronchial tubes as well, and even lead to having mucus in the alveoli, which we don't want to have. For the average person, too much mucus, what's the big deal with that? Well, it acts as a feeding ground for bacteria, so this person will suffer many respiratory infections in their life, so it's super easy for them to get a respiratory infection. The average person with cystic fibrosis has a lifespan of about 30 years and generally dies from some sort of respiratory infection. So again, pneumonia, for example, bronchitis, those things are super easy for these people to get, and then very difficult to get rid of because of the mucus oversecretion. I have read that light exercise is actually great for people with cystic fibrosis, particularly aerobic, moderate intensity. And the reason for that is they believe that that helps to facilitate movement of that mucus and might help to get some of that kind of worked out of their systems. So I know that is one potential treatment. However, there isn't really a cure for cystic fibrosis at this time. Oh, I have one more. Okay. COPD. Chronic obstructive pulmonary disease. This is one of the leading causes of death in America. Generally, not always, but a lot of the time, most of the time, patients have a history of smoking when they experience COPD. They will experience dyspnea, which is basically labored breathing, like out of breath, like how I feel when I walk up the stairs anyway, I guess. But they will experience this very commonly from very minimal movement. And so what's going on with this? So they're going to get chronic inflammation of their respiratory tubes. The lungs are going to become less elastic. Generally, that can occur from chronic smoking. The lungs become less elastic, so you lose some of that elastic fiber in that particular scenario, and the bronchioles can collapse during breathing. So again, can be pretty problematic in that particular scenario. All right. That is it for the respiratory system. Please reach out if you have any questions. I hope you have a great day, and I look forward to seeing you again soon.